It's my great honor to give a talk and share my experience to you. I have been in Stanford at 2000, so it's 70 years ago. So when I was very young, like you, and I really inspired a lot from Stanford. So I believe you will have a very fantastic academic career from Stanford. So today, what I'm talking is sleep surgery, changing concept, diagnosis, and technique. Actually, it's a Taiwan experience. So we all know the medical treatment will be largely influenced by the insurance system and the background culture. So I want to tell you is in Taiwan, the insurance does not cover the CPAP, but cover the surgical fee. So Taiwanese people will be very brave and very keen to receive operation. And another reason is in very Oriental culture, they don't think the CPAP is a treatment. They think the CPAP is just but a machine, a device. It's not a permanent treatment. So that's why in Taiwan, the majority of the patients, they seek for surgery for their OSAS treatment. Taiwan has been known to be one of the best 10 countries in the world to travel. So I sincerely welcome all of you to Taiwan if you have time to join a conference or have your vacation. So today, the changes in surgery, diagnosis, and technique. What I want to share with you is the changes in the concept, diagnosis, and the technique. It means the concept in terms of the purpose, the priority, and the endpoint will change in recent years about how to treat the OSAS by surgery. And we do another, not only the dice, but also we do a lot of the sleep CT scan, and we did have very different findings from the CT scan because the dice is a very intraluminal endoscopic examination. You cannot see the obstruction from the sagittal view. So that's the difference from the finding from the sleep CT, and we do a lot of sound collection and try to find the obstruction level from the sound. Because from the probably in the future, we can record the snoring, and probably 10,000 of the recording, and we put to the computer to analyze like artificial AI. So we can see probably the obstruction side from the sound, snoring sound. Probably that's an alternative to dice. And the technique, I would say we will do it more functional. We try to not to cut the tissue, not to excise the tissue, but try to put the tissue in the right position and try to suspend the tissue to enlarge the airway. So that's why we revise our surgical technique. So the change in the concept is the first one, number one is the etiology. I think it has been debated for probably 30 years. Is OSAS is a neurological disease or anatomical disease? I think the answer is quite clear now. Because when we say it's an obstruction, it's a phenotype. When we say it's a collapse, it's a genotype. So I would say for OSAS, the etiology is both anatomy and neurology. So it means it's a problem of proportion in different patients, the different proportion. Some patients, they are majorly anatomy. For some patients, probably they are neurological disorder. So the second concept change is the purpose of sleep surgery. In the past time, we say sleep surgery is trying to improve snoring, daytime sleep, or decrease the risk of the cardiovascular coronary disease or to decrease the traffic accident. But in recent research, I would say some ENT disease is very close to obstructive sleep apnea or sleep apnea because of hypoxia mechanism. As we all know, the blood supply to the eye and to the inner ear is very tiny. So it's very distal organ. So if you have hypoxia, you probably will largely influence the inner ear function to lead to the tinnitus, vertigo, or hearing loss. So if in the future, when you get a patient of sudden deafness and you treat with CPAP, I would say I will not surprise. So that's another our research. So you can see this sleep apnea and the risk. We have a big data from our national data bank. So you can see the part of time from 4 years to 10 years. There's no sleep apnea patient and the sleep apnea patient. You can see the prevalence is quite different. So sleep apnea is an independent risk for vertigo, so as in the tinnitus and the hearing loss. So as an ENT surgeon or sleep surgeon, we need to know a patient of sleep apnea could have potentially risk of vertigo in the future. So it's an association between the two diseases. So another our research is snoring sound and we know atherosclerosis. So because we are wondering why so many patients they have atherosclerosis in the common carotid artery, not in other artery, but it's very common in common carotid artery. So we try to correlate the snore sound with the atherosclerosis. From to check ultrasound to check the intima thickness, and we found the middle pitch and high pitch snore sound is correlated with thickness of atherosclerosis. You can see it's very clear the geography location. High pitch, middle pitch for the snoring flutter from the esophagus. I can have a simulated. That could be 100 or 200 hertz. But from the tonsil, that could be 500. From the tongue, that could be 1,000. So it's a middle and a high pitch energy snore sound will be correlated with nearby common carotid artery. So it's an acoustic trauma. So it's an acoustic trauma. Another theory is a vibration theory. So what is the snore sound of the vibration of the master wall? So the person will be more easy to hear when there's a vibration. So in these two theories, so maybe we can at least partially explain why the snore sound is correlated with atherosclerosis. So I would say snore sound is not absolutely not harmless. In the middle pitch or high pitch snore sound, they will have very high correlation to the atherosclerosis. So we cannot say snoring is okay, snoring is harmless, because the different type of snoring have a different effect to the blood vessel, common carotid artery. So again, I propose one system, because for the head and neck cancer, we will say it's a T1, N1, or N0 or M1 TNM system, and for the sleep surgeon, And I would say probably we can consider the soft tissue surgery. It means intrapharyngeal surgery as a local, the MMA as a regional, and the bariatric surgery as a systemic. So it will be very different function. For the intrapharyngeal surgery, that's to excision, tissue volume reduction, or suspension or relocation. For the MMA, it's an advance or stretch. And for the bariatric surgery, they will have a very systemic tissue volume reduction so as to reduce the negative thoracic pressure. And then the priority of the OSAS. When I was a student, a medical student, and a resident, and the visiting staff, I was told CPAP is a gold standard, and the first line the treatment for sleep apnea. But in my 20 years clinic, I believe for elderly, for patients with very excessive daytime sleepiness, very severe or obesity, or you cannot see any anatomical deformity, or previous stroke or heart attack, I will say no problem. CPAP is a first-line treatment. But we can see more young patients, 20 years old, and only snoring, no daytime sleepiness, probably more mild disease, and with nasal obstruction or obvious anatomical deformity. I would say in this condition, probably we can do surgery as a first-line treatment, because when I report this patient to receive CPAP treatment, 80% of patients is scared, and 20% they have their CPAP but with poor compliance. Only 50% probably will get CPAP for more than 3 months. So I would say a CPAP is a golden treatment and a first-line treatment, usually, but not always. CPAP is one treatment. It's one treatment. It's one option. Nothing more, nothing less. So the treatment modality, as we all know, for the severe OSAS patients, they usually have multi-level obstruction. So there's always need a multi-level treatment or multi-modality. What I mean multi-modality is you can combine the medical treatment with surgery. But what I want to say is we can do more than this. We need actually an integrative treatment. So what I mean integrated treatment, you need a triad. We need to have a training that patient to always have nasal breathing. So it's some respiration training from the daytime, and then have an effect during their sleep. So we need to keep the patient have a nasal breathing the whole day and the whole night. The second is muscle training, right? And the third is positional therapy. For example, it's quite usual and very common for ENT surgeon to treat the one severe OSAS patient, for example, 42 to probably 13 after surgery. But the patient can have a long time to sleep in the later sleep, and the HI could be reduced to 5 or 4. So we need to ask patient and give patient the adequate positional therapy so as to get integrated treatment to increase your success rate. So the last for the concept change is endpoint. So previously we say Shear's criteria to success, surgery success, the HIS 20 and 50% is reduction, but it's all from data. What I want to say is we need to treat the patient, not the data. So it means we need to do it more holistic. So I would say probably we need to reduce to mild and to involve two major clinical manifestations, the daytime sleepiness and the snoring. And we can check our, for example, high sensitive CRP to keep the patient in low risk of GVA and coronary heart disease. I think probably that will be more comprehensive to explain the result, not only for HI value. So we need to think about the patient's feeling, what patients want, patients wish, not only the PhD data. So the second part is to speak of some changes in the diagnosis. Okay, the Freeman stage, I think that everyone knows Freeman stage. So from the Freeman stage, we know the anatomic staging is more reliable than severity staging. Anatomic staging is more reliable stage for the outcome of esophageal surgery. If you do a UBBP, you try to get a good outcome, surgical outcome, you need to choose the early stage of the Freeman stage. Freeman stage is not so accurate, honestly, but it's much better than HI, because HI can tell you nothing about the obstruction site. Okay, I think this slide is, for me, I would say it's important. I would say when we do a drug-induced CT, the most important part is two things. Number one is from the lateral view. So you can see the anterior-posterior obstruction from the lateral view, and you can see the sequence. It's from upper than from low, or it's upper plus low, or it's just upper. So, and you cannot see it from the, so it's the upper tongue obstruction. Upper tongue compress the soft palate. And it's a low tongue obstruction. And it's upper and low. You can see it's upper and low. You can see that's epiglottis collapse. So we found it's about 30%, 1/3 and 1/3 for the upper low and upper plus low. So you can explain why you do the TOS or do some tongue-based surgery. You will not get a very high success rate because you escape the upper tongue obstruction. Furthermore, if you do a tongue-based surgery and the patient actually had upper tongue obstruction, it means tongue body obstruction, you actually make the HI worse because the tongue, the supporting strength make after surgery make it weak, so it will be more easy to collapse. So try to have the whole profile. The tongue is an integrated organ. It can obstruction in the upper part or low part or both parts. So if you try to relieve the tongue obstruction, don't try to treat only tongue-based obstruction. I think that they will give us some very clear, very different idea. And the epiglottis obstruction is around 25%. So, but epiglottic collapse, you can see it from the DICE. And DICE is very common and should be done in every surgical patient. But what I'm going to say is, when we do a DICE, we found in our study population, there is a few patients, they have arytenoid collapse. It's a suction power to cause arytenoid collapse. But this phenomenon never been reported in the previous article. And so we try to find probably it's a difference in race. or Caucasian and Asian. It's just like for ENT, it's very common, laryngomalacia. So in all such patients, in elderly patients, they could have some arytenoid sucking. So in this condition, they will have very poor compliance to CPAP because CPAP they will induce the arytenoid collapse. So in this patient, to do the for ENT is very common to do the supraglotoplasty by laser. It will find. So the arytenoid sucking arytenoid adduction will, I would say it's not a rare in Asia. So the snow sound, we do a lot of application here, and we found there's low pitch, middle pitch, and high pitch. So it is the flatter, tonsil epiglottis, and the tongue. So we define a lot of the very different type. So very different type can be corresponsible to very different obstruction site. And the last part is about our surgical technique. So in this slide I will share with you is I will see the extrapharynx surgery is a traction. It's a traction. You advance and rotate the mandible and the framework. Actually, you stretch the lateral pharyngeal wall, the great lateral pharyngeal wall, and so as to get the result. The intrapharynx, I would say, probably we can see the intrapharynx surgery as two parts. First part is excision. Like the nose, we excise the deviated septum, the part that we remove part of the fat, tonsil, or partial, this part of uvula. For tongue, lingual tissue, lingual tonsil, and epiglottis, some cartilage. Another way is the suspension. We can suspend the soft palate. We can also suspend lateral pharyngeal wall, or we suspend tongue base or hyoid bone to get a suspension effect to advance or to enlarge the upper airway. So I would say probably we will not do too much excision, but we can do the suspension to augment the upper airway. For surgery, nasal surgery, there are 2-3 parts: nasal border, nasal septum, and cartilage. So I would say that's a functional nasal surgery. Try to protect the great palatine artery and to correct the septum and the intra-septum suture with the drainage, and then fracture or fracture the perimeter. So you may do not need to hack the nose. So I think it's very important for the OSAS patient if they can use the CPAP the day after surgery. That's some of our reports. The surgery improves snoring, daytime sleep quality of life, and some probably can be shared with you is outcome predicted of nasal surgery for snoring. Actually, it's tonsil size. If you choose tonsil 1, you get a better outcomes in the reduction of snoring by nasal surgery. You try to reduce the HI by nasal surgery. You choose the prevalent composition 1 or 2A. If you choose the 3, the HI will not change. And nasal surgery for the CPAP, in our study, nasal dimension is related to CPAP compliance. So if you have a small nasal dimension, we can expect there will be a poor nasal compliance. Published in sleep. So for the palate surgery, actually I would say the palate surgery, the surgical plan is based on the direction of collapse. If that's an anterior posterior collapse, I will do the palatal surgery. It's a lateral collapse, I will do pharyngoplasty. It's a concentric obstruction, I will do a composite palatal pharyngeoplasty. So let's do this. So for the lateral pharyngeal wall collapse, we just spring the lateral pharyngeal wall in terms of suprapharyngeal muscle. So that's a surgical procedure. And today I would like to show you another problem is when you suture the tonsil fossa, it's a very, very common to have a dehiscence of tonsil fossa. So in Taiwan, we do a tonsil religion dissection. So actually, when you see a ridge here, so you use I use the plasma knife to cut here, and do some dissection of the heating. Sorry. So there's no change of the patient's voice, speech, and articulation after surgery. I think the video is fantastic here. All right. For the UPV value, the post CT scan is to present the tongue-based obstruction. So the UPV value could be from the hypopharyngeal obstruction, and that's epiglottic collapse. And this picture is a persistent soft-hearted collapse. So tibial artists always emphasize there's a multi-level obstruction. So focus on the tongue-based tongue and the epiglottis, but actually more than 50% we have persistent or residual heart obstruction. So from last year, it has been complete 1 year. We call it a suspension polyplosy. This technique is actually inspired from Professor Vicini, the labral reposition polyplosy. So we use the pterygomandibular raphe as an anchor, and we just fix the palatal pharyngeal muscle to the raphe so as to suspend the soft palate. So you can see that's a routine UVB, the anterior posterior dimension. That's after suspension. So you can see the difference between the routine UVB and the suspension palatoplasty. I'm very frustrated. Why? So I need your imagination. So this is a two video. The number one video is when I have a suspension to just pull the two strings to upward, and the low video is we have a 70-degree endoscope to see the widening of the soft palate. So it's very amazing. So you can see the very collapsed soft palate. When you have suspension, so you will have a very wide widening. So that's the outcome of suspension palatoplasty to improve the snoring, daytime sleepiness, and you can see this before surgery, is after surgery. So that's particular increment in the anterior posterior dimension, and it's from the lateral cephalometry, the PS. So another two demonstration is in moderate OSAS patient, you can see the collapse here, and after surgery, after suspension, you can see there's very severe suspension and after suspension. That's from the 0-degree endoscope. It's from 70-degree endoscope prognosis. That's lateral separometry before and after. So you can see the suspension. You can see the move forward from a very high level. The soap part that move forward from a very high level. So that's suspension palatoplasty. So I would like to enhance 3 points. The anterior pillar here. Anterior pillar do connection with the tongue. I think it's very important. So when you are doing a UBBP, do not jeopardize this part because it's a connection to tongue. If you cut here, it will make the tongue unstable. So try to protect these 2 parts. And because the stable tongue will have a stable retrolingual space. How about the posterior? Posterior actually is the best place to suspend the soap palate. So to protect the anterior pillar here. Posterior, sorry. And the tonsil fossa is used to maintain the retrovorsal space. If you remove the tonsil and suture it together, so you just pull the posterior, pull the tongue backward. So if you have a reconstruction of the tonsil fossa, so you can prevent the retrolingual space. So it's 2 different conditions. So I usually use the plasma knife. Because of low thermal injury, to prevent or to decrease the tonsillar fossa adhesions. And for concentric obstruction, like in so, you need to do the both sides, anterior, posterior, and the lateral. If you do one side, you will have very low success rate. So you need to, because it's concentric from the lateral and from the anterior posterior. So I will suspend the superior phalangeal constrict muscle and suspend the palatopharyngeal muscle, so as to increase anterior posterior and the lateral. So for hypopharyngeal surgery, I think Dr. Cavasso and Sandy, you do a lot about the MMA and the airway stimulation. So in Changan, we do a lot of robotic surgery tools. So previously, we do the mini-lygosectomy by shield laser or NDI laser to remove the tongue or lingual tonsil by the handpiece or by NDI laser. And stimulation, or we can use the robotic surgery. And the important is how to design your excision position. For me, I will, after the dice, I will use the separometry to design our surgical plan, how to, and to weight how many grams of my lingual tissue. So another way is what we design is we call it collaboration endoscope lingual lightening. So it's use collaboration, patient and use collaboration to remove the lingual tissue and have an extension incision to remove the lingual tissue in the lingual tonsil. This is a surgical design. So actually, the collaboration endoscopic lingual lightening is including open glossectomy for tongue base, open glossectomy, and the submucosal debulking of tongue body. So it involves the tongue base and the tongue body. That will be corresponding to my viewpoint. The tongue is an integrated organ, so you need to treat tongue body and tongue base both. So you can see some upper tongue and some lower tongue. So it's quite different. And these last two slides, epiglottis. Usually, we will not pay full attention on epiglottis, but some of my cases, they have the nose, palate, and tongue surgery. After that, we found they still have a very high HI, and there is an epiglottic collapse from the CT. Sorry, that's a CT scan. It's a very high epiglottis collapse. So after surgery to remove partial of the epiglottis, and there was short epiglottis, and there was no collapse of the epiglottis larger obstruction. So the HI decreased to 16. So because we do the stage operation, so we can see that this effect is actually from the larger surgery of the epiglottis. This is my last slide. So SIP surgery for us 2017, I will say we do a lot of change in surgical purpose. Especially in the future, we may have some to treat the tinnitus, to treat the hearing loss, to treat the vertigo with CPAP, probably, if we have a strong evidence to connect both. And surgery is not always a second-line treatment, especially in young people, in mild, in only snoring, and for patients, they are not unwilling to receive CPAP. Probably we don't have to use the CPAP as a post-line try. We can direct to the surgery. And we needed to have a treatment plan for the patients as an integration. It needed surgery or medical treatment. And for the in need triad, we need to keep the patient and nasal breathing. For long-term result, we need to train in the muscle, and we need to give the patient instruction how they can have a long time to sleep in one side. So the sleep position. So we need the triad to enhance your surgical effect. For the examination, I would say we need to do the drug-induced examination, sleep examination, no matter from endoscope or from image. Image, you need to concern the radiation. But from endoscope, because now that's endoscope, that's our home yard, our backyard. We can do the endoscope before surgery or in another time. So we need to do some sleep examination, not a lunus management. And again, probably snoring sound is another alternative because it's just like echo. It's non-invasive. Probably snoring sound analysis is an alternative to the endoscopy. The technique, I would say we will do it more functional. No less cutting, less excision, but do more functional. We remove fat. We just reposition or relocation the tissue to a more to get an advantage, and we do it more functional and to stabilize the tissue and to avoid some complication. Actually, we try to minimize the complication and maximize the effect. So that's the change of technique. So quickly, I finish my presentation, and I hope they will be helpful to you. And thank you very much.
Dr. Lee, thank you. That was a privilege to have you here.
Thank you. My pleasure.
Share some of this great experience, that many publications, that many projects. That is great. One quick question for you. When do you choose the patient for cell versus stores? Is there a particular tool that you give, that you prefer one patient versus the other?
There's a time frame.
Okay.
before I do the toss,
Okay.
you say.
Okay, good enough.
And again, it's a sorry. Again, it's a you need to consider the the medical cost.
Okay.
It's about it's about 10% of the toss.
Okay.
Toss is very expensive in Taiwan.
Yeah.
Sorry.
Can you comment on patients who have overly treated uvulas? Had some patients who have a persistent feeling of mucus stuck in their throat, and whether you feel that uvula is purely vestigial or it has function to clear mucus off the posterior family wall.
Right. It's a very good question. If you excise, do the total uvulectomy, and you cause a scar in the soft palate. So when you swallow it, the tongue will touch the scar. So there will be a lumping in your throat. And you do the total excision of uvula, they cannot strip out the mucus. So there will a sensation of mucus containing in your throat. So if you do the uvulectomy, you are trying to do a partially, the non-muscular part. You preserve the uvular muscle. So you will just avoid this complication.
Two questions. When you do excise the uvula, like they used to do with the layup, why do patients aspirate more with liquids? Do you find that to be true without a uvula? They aspirate?
That's correct. After
When they drink liquid, it goes down the trachea.
okay, I think the pharyngeal architecture contains two major parts. It's the uvular muscle and the digital muscle. If you do palate surgery, if you do not damage the digital muscle and the uvular muscle, they can close completely. So that's why we designed the surgery technique from the lateral side, from the up, not from the upper side. Because from upper side, you will create a crack palate like a wound. So that's a disaster because it's not exactly open the video pharynx, but will cause very significant nasal regurgitation. So your surgery from the lateral side and remove the fat, not the muscle. So we preserve the digital muscle. So they will, I don't have the permanent aspiration from the nose.
Second question. The tongue regenerates. If you excise portions of the tongue, what prevents it from growing back in 4 to 6 months again?
It means the 6 months.
Within a short period of time, the tongue regenerates. No matter what you do to the tongue, it regenerates. It grows back. When you do the midline tongue excision, in 6 months, why isn't it right back again, obstructing?
Yes, but I would say if you do the tongue surgery, use a cooperation, I think the shape will not change a lot. But if you use the toss, because it's monopolar, so you usually, in average, I get the 6 gram of the specimen.
Mm-hmm.
So after the toss tongue surgery, and again, you can get the benefits about 30% of shrinkage. So when you do an endoscopic examination, you can see a very wide hypopharynx. So it's quite different from the cooperation. So 6 months, probably you can get a follow-up for 1 year. The surgery result will be better because they will have a consistent scarring of the tongue.
Thank you.
Thank you very much.